So our first presentation is from Donna Cohen of MirMap Proprietary Limited, and she's talking about making quality everybody's business, which of course is what we would all hope that we can bed that down. But this is a new approach to engaging staff in quality improvement. So Donna, I'm going to hand over to you.
Thank you. Great. Well, thank you very much, Karen, and thank you everyone for coming along. So last year, a report was released following a review of hospital safety and quality assurance in Victoria that was prompted by a series of preventable baby deaths at a Victorian health service. The Targeting Zero report from the panel that was chaired by Stephen Duckett, which you may be familiar with, was largely focused on the deficiencies in oversight and governance at the departmental level, which of course was the terms of reference of the review. So most of the report's 10 recommendations were in relation to structural, legislative and departmental policy changes, and progress has been made on a large number of these, including the establishment of a new peak authority, which is called Safer Care Victoria. But it would be fair to say that the implementation of these recommendations probably represents the easy part of the equation. The hard part, the really challenging part, comes now. Namely, how do these various structural and legislative or policy instruments affect real change in quality and safety at the hospital coalface to ensure that that goal of zero avoidable patient harm at the hospital coalface is actually being realised. Now, importantly, the Duckett report acknowledged that the issues highlighted in the review were not new. And one of the reasons that these issues persist is because whenever they are raised, the response has generally been to double down on the approaches that are already in place. So we look to strengthen accreditation, or we look for better indicators. I think it was Einstein who reportedly commented on the folly of such a strategy. The inescapable reality is, if we want a different outcome this time around, we need to try different approaches. And that's not just in governance, that's at the coalface as well. Now, around about the time that Duckett and his colleagues were finalising their report, a Melbourne private hospital emergency department was doing just that. They were trying a different approach. Now, over a 3-month period, the ED had recorded a total of 13 riskman reports relating to patient identification and procedure matching. And if you're not familiar with it, riskman is the system that's used in Victoria to record adverse events and incidents. Now, the nurse unit manager of that ED was obviously concerned to address these issues, and she was very keen to engage and involve her staff in the quality activities. And she took up a suggestion from one of her team members to try out a new quality tool. So during one afternoon handover period each week for 4 weeks, they used this tool. Over the next 2 months, the number of riskman reports in the ED relating to patient ID fell to 0. Now I'd like to show you how they did it. So the tool that they were using was based on an innovative approach to quality improvement that my colleagues and I have developed, which we call MIR, Map-Enabled Experiential Review. This is a process review technique that uses an interactive, graphical representation of the process that's being assessed as the basis for structured, team-based conversations about routine practice. Now, when we started developing this approach, there was plenty of software around that allowed us to draw our process models, but none that allowed us to use those in the interactive way in which we had envisaged. And so we developed our own software tool, which is called MirCat, spelled with a Q for quality. So here is one of the process models that's created in MirCat. We call these base maps. Now, the detail is not particularly important, which is probably just as well, because I don't think that you can see it at this resolution. But what you can see is that this is the model for patient identification that that ED team used. You can also see in the lower right-hand corner, there's a legend there that shows you that each of those color-coded rectangles, which we call nodes, represents an input, an activity, an output, or an outcome by which the health service would achieve the objectives of the standard. So the ED team that was conducting this assessment had that model projected up on the wall. And when they click on one of the nodes, it opens up a dialog box. And I'll show you this now in a bit more detail. So the dialog box has been designed to lead the group through a structured conversation about how well that particular aspect of the system is being achieved. You can see that this is an input, in this case health service policies on patient ID, and there's more information about the node and the rating question that they're asked to consider revealed behind the question mark. You can also see that there's a rating scale there, and that rating scale helps to provide structure for the conversation and guide the discussion that the team is having. The interface is clickable, so as the team is discussing how well they are experiencing this particular aspect of the system, both individually and collectively as a team, they can record by clicking on the interface what the individual members of the team, how they rate that particular aspect. They're also able to attach documents and add comments that support the ratings that they have given. So this discussion is actually pretty central to what is going on there. And when they finish that discussion, they move on to the next step of the process, which is working out what their overall consensus is as a team for this particular node. So they click on the next button, identify their consensus rating, and then click on the next button again, which takes them to the final screen where they're asked to consider whether they want to include this particular node in their quality improvement action plan. No point in identifying issues if you're not going to do something about them. Now you can see that the tool does make a recommendation about whether to include this node in the action plan, and that recommendation is based on the poll ratings that are summarized there and also the consensus rating that's been given by the team, but the team can override that if they want to. Now when they click on the Done button, a little icon appears, thank you, in the top right-hand corner of the node, which reflects the overall consensus rating that was given by the team. If that consensus rating was either an average or a below average rating, it gets a little orange hazard icon, whereas if it's an above average rating, it gets a little purple tick. And when all of the nodes in the map have been rated, you can see that that ED team would have received a sort of instant snapshot of where there were issues that they had identified that needed some attention. Now, if they nominated those issues for inclusion in their action plan, they appeared as a card in the to-do column of the integrated action planning tool. And those cards can be expanded. They can add some tasks that will address the issues that they've identified. They can assign them to individuals. They can set a due date for them. When work gets underway on the tasks on the card, they can drag it and drop it into the in progress column, where they can mark off if a task has been completed, and when all the tasks on the card have been completed, they can drag it and drop it into the done column. In terms of accountability and reporting, the tool also allows them to produce some reports on their assessment, either single assessment reports. If they repeat the assessment in a few months' time, they can run a comparison report comparing the later and the earlier assessment. And if other units within the hospital also assess themselves using the same base map, then the organisation can run a comparison report comparing the consensus ratings that each of those different units has recorded, which of course is very useful to determine whether or not you have some local issues that require local solutions as opposed to more widespread issues that might require a more organisation-wide solution. So basically, this was the approach that that ED team used that took them from 13 Riskman reports to 0. Now, essentially what they were doing was a form of map-based simulation. Now, I've seen a lot of presentations in recent years about the very successful use of simulation as a quality improvement tool. And they'll do this, for example, taking a whole scenario, say a trauma victim arriving and being treated in the ED, and they will go from go to woe, and this is all being videoed. And then they will sit the whole team down to review the video. Anyone who was involved in any way will review the video, and they'll discuss what they did, why they did it that way, and how they think they can do it better. Now, obviously, most hospitals could not afford such an approach, and certainly not as a means of reviewing and improving every activity that they undertake. But actually, the MIR technique is tapping into the same principles, but it's using the graphical interactive map rather than a video of a simulated scenario as the framework for a discussion about routine practice. And indeed, the reasons why this intervention has worked are very similar to the reasons why simulation is such a useful tool in the context of quality improvement. Firstly, and most importantly, the use of this tool encouraged good old reflective practice amongst the participating staff. So this was both at an individual level and also at a team-based level. A no-blame approach to the discussions encouraged the staff to reflect on what they do as part of their daily practice, why they do it that way, and then to honestly rate the collective performance and behaviours of the team. And very importantly, of course, they carried this reflection out of the discussion session and onto the floor. Secondly, the staff found the sessions to be educative. So the note descriptions explain the importance of the various different aspects of the daily practice in terms of achieving the objectives of the standard. And in many cases, this served to inform staff about things that they either were never aware of, or if they had been aware of it at some time, they had long since forgotten. And of course, when staff understand why they're meant to do something in a particular way, they're much more likely to do it that way. But the conversations were not just educative, they were also structured. So if the nurse unit manager had sat her staff down and said to them, look, we want to have a conversation about the processes associated with patient ID, of course the question is, where would she begin? And how would she ensure that she discussed everything with the team, not just the obvious things, or for example, the pet issues of individual team members? Fourthly, the MIR activity helped the team members to identify where their daily practice was deviating from a standard protocol. And we've heard quite a lot at this conference about the importance of this protocol variance. Of course, it's not that individuals set out to deliberately implement protocols and procedures incorrectly. It's just that as a matter of course, staff will introduce some variations into their daily practice. And often this is to meet their daily circumstances, and sometimes it's to meet their work preferences. Of course, some of these changes may improve the process, many do not, but almost none of these are ever documented. On their own, these deviations of practice, they usually go undetected because they don't appear to cause a problem. And because they're tolerated, of course, they become the new norms of practice. And indeed, any staff who are required to train new team members are very likely to teach their own version of a protocol to others, who then in turn add further adaptations over time. And eventually, as we know, cumulative adaptations to protocols may tip the protocol over a tolerance threshold, sometimes with catastrophic consequences. So this phenomenon, which is known as normalized deviance, is discussed at length in this 2013 report from KPMG. This report identified protocol optimization and standardization as one of the 4 building blocks of high reliability healthcare organizations. And the report noted that in hospitals across the UK and North America, when organizations take steps to reduce their protocol variance, this results in dramatic improvements in patient health outcomes, as well as reductions in the costs of delivering care. So the MIR activity was providing a means for the ED team to identify and rectify their instances of protocol variance before some catastrophic outcome brought it to their attention. Fifthly, the use of the MirCat tool allowed the team to immediately translate the issues that they had identified in the course of their assessment into tasks within a quality improvement action plan. And importantly, this helped them to see the quality improvement part of the process as directly related to their daily practice, rather than as some abstract set of activities that was imposed on them by someone else. Related to this, the MirCat sessions were very engaging for the staff, for the participants, and it helped them to develop a sense of ownership, both of the diagnosis of the issues and also in identifying strategies to remediate those issues. And so instead of seeing quality improvement as the business of the quality manager or the business of the nurse unit manager, they started to see it as their own business. And finally, the MirCat sessions helped the team to build what is known as their collective competence, as they developed a shared understanding of the work practices they all contribute to. Now, I have to say that we were not particularly surprised that this MIR approach did work with this ED team, because this same approach has actually been used in Victoria since 2012 in a tool called BPCLE tool. This tool was developed by us to assist the Victorian Department of Health and Human Services with statewide implementation of a quality framework for clinical education, a framework called the Best Practice Clinical Learning Environment, or BPCLE framework. Now, this tool is currently being used in every Victorian public health service and registered community health service, as well as a number of other health and social care services in Victoria. Stakeholder feedback on this tool has been very positive. More than 80% of respondents expressed satisfaction with this tool. More than 70% would recommend to another health service that they use this tool to implement this framework. And 80% told us that the MIR process, which is at the heart of BPCLE tool, provided a very positive learning experience that genuinely engaged the staff. So in conclusion, with the MIR technique, we have an approach that has already been shown to work in a health service context through BPCLE tool, and which addresses two of the key factors that contribute to quality and safety issues in health services, namely staff engagement in quality and persistent protocol variance. We're now working to explore the full potential of MIR in the context of health services. So we've developed a number of process models that can be used off the shelf or can be adapted by organisations to meet their particular circumstances. This includes a number of the acute care quality standards, as well as models for the residential aged care standards and also the home care common standards. And a growing number of organisations are adopting this approach. So in Victoria, we have Epworth Healthcare about to start their implementation. They're planning to use base maps for 5 of the NSQHS standards in 2 of their clinical units at their Richmond Hospital campus. We have a community health service in inner eastern Melbourne that is using the MIR approach to review consent procedures across their multiple sites. We also have a home care provider in South Australia who is using the MIR approach to assess against the home care common standards, and this is forming the centrepiece of their quality assurance system. And we are similarly in discussions with a major aged care provider in Victoria for a similar outcome. And we are also talking with Safer Care Victoria about how the MIR approach could be used to help them with implementing key recommendations from the Duckett report. Which brings me back to where I began. If the Duckett report is going to represent a turning point in addressing preventable patient harm, then I think we need a rethink on the approaches that we use to address quality and safety. With MIR, we believe that we do have an approach that can deliver exactly what is needed to effect real change in quality and safety at the hospital coalface. An innovative approach that will help to put quality improvement back where it belongs, embedded in regular, team-based, reflective practice by frontline clinical staff. Thank you.